So we'll continue with the salivary gland diseases or disorders. So we discussed xylolith, mucocele. Under mucocele, we discussed about the mucus retention cyst and the mucus extravasation phenomena. And we also studied oral ranula and cervical ranula, which is oral ranula is a form of mucocele actually. So in this lecture, we are going to study what is called as Sjögren syndrome. It's pronounced as Sjögren, okay? And we'll study the clinical presentation, what is the cause, what is the histopathology, and what are the differential diagnosis and treatment of it. And we'll also be studying what is called as necrotizing metaplasia. Again, the same features, that's your clinical, histopathologic, and differential diagnosis, followed by treatment. Okay. So before that, I just want to mention one particular condition called as sialosis. This is a non-inflammatory and non-neoplastic salivary gland disorder. So if you remember the classification, there was obstructive disorder, there was functional disorder, there was non-neoplastic disorder, and then the neoplastic disorder. So sialosis is a non-neoplastic disorder, and it is neither associated with inflammation as well. There is repeated bilateral swelling of the salivary glands. Okay, here also. And the cause is unknown. It is of unknown cause. Nobody knows why it happens. And the etiology is very important because that's how your treatment is planned based on the etiology. But in this case, you don't know what is the cause, and it is usually seen to be associated with any kind of hormonal disturbance, malnutrition, excessive alcohol consumption, liver cirrhosis, and protein deficiency. So there is some kind of association seen with all of this, but there is no particular reason where you can pinpoint and say this is the cause. That's why it's considered as non-inflammatory and non-neoplastic. So we'll continue with the other disorders, the salivary gland diseases. That is, the Sjögren syndrome is an autoimmune condition. You know, the body has an immune system, right? There is humoral immunity, there is cell-mediated immunity. So these two immune systems are present to protect your body from the external agents, whatever type of agent it might be, but it is there to protect you from the external agent, and it attacks those external agents, and whatever your phagocytosis happens, it engulfs and kills these agents. So that's the whole idea behind immunity. But in autoimmune condition or autoimmune disorder, the immune system or the body somehow recognizes its own cell as foreign, its own cell as harmful, so it attacks its own cell and kills it. Okay, so that is an autoimmune condition. There are several other autoimmune conditions. Go home and read them. It's very interesting how it all works. So Sjögren's disease, which is a salivary gland disease, is one such autoimmune condition. Okay, so it is defined as a chronic systemic autoimmune disorder which is characterized by lymphocytic infiltration and acinar destruction of lacrimal and salivary glands. Lacrimal is the glands for your eyes, okay? Resulting in dry mouth, which is referred to as xerostomia, and dry eye, which is called as xerophthalmia. So xero, this term is used whenever there is dryness. Stoma is for the mouth, so dry mouth is xerostomia. Ophthalmia is for the mouth, so xerophthalmia is for the dry eye. Okay, so it's an autoimmune disorder that we have figured it out. And what does it show? It shows intense lymphocytic infiltration and acinar destruction. Acini, as you know, are the functional structures of your salivary gland. Okay, it could be mucus acini or serous acini, but that's the basic component of your salivary gland. So those undergo destruction. And two areas which are mainly affected, your mouth and the eyes. So there is dryness of the mouth called as xerostomia, and there is dryness of the eye called as xerophthalmia. That's the definition of Sjögren syndrome, which pretty much also explains its etiology, that is, it's an autoimmune disorder, its histopathology, and clinical features as well. Histopathology is this, clinical features are these two. And the effect on the eye, that is the xerophthalmia, is called as keratoconjunctivitis sicca. Okay, you know there is conjunctiva of the eye, right? So sicca, again, the terminology means dry. So keratoconjunctivitis sicca is something which is seen in association with the eye. And when xerostomia and xerophthalmia both are seen together, it is called as a sicca syndrome. Okay, syndrome, as you know, you must know that there are combination of diseases, combination of pathologies. So sicca syndrome is when both your eye dryness and mouth dryness, that is xerostomia and xerophthalmia, are seen together. So because it is autoimmune, you don't know what is the cause, what is triggering this kind of a reaction from the body, you don't know. There were some people who said some kind of association with the viral etiology, especially the Epstein-Barr virus and even the human immunodeficiency virus, that is the virus which causes AIDS. So there was an increased serum titers of these antibodies in patients with Sjögren's disease, so they associated them with these two. But it is essentially an autoimmune disorder. It is not really a viral. Probably this is a coincidence that there was an increased titer of these two viruses. The own salivary gland tissue becomes antigenic, resulting in the production of circulating autoantibodies against them. That's what leads to the necrosis of the salivary gland acini, or the destruction of the salivary gland acini. So there are two types of Sjögren's disease. One is primary Sjögren syndrome, and the other, of course, is secondary. So in primary, you just see the sicca syndrome. Okay, there is no other autoimmune disorder present. So what is sicca syndrome? It is a combination of dry eye and dry mouth and dry eye. Xerostomia and xerophthalmia is called as sicca syndrome, correct? So that's the primary Sjögren's disease or syndrome. Secondary Sjögren syndrome will have the sicca syndrome, that is the primary Sjögren syndrome. Along with that, there are some other associated autoimmune diseases affecting the connective tissue. Like, for example, there is rheumatoid arthritis and systemic lupus erythematosus. I hope you have studied it in your syllabus somewhere, either in oral pathology or general pathology or wherever. So I'm just going to tell very, very briefly. Rheumatoid arthritis is which affects the joints. Okay, all the joints will be affected. There will be severe inflammation of the joints of the bones. Okay, arthritis. Itis is inflammation. Arth always refers to your bones. And systemic lupus erythematosus, you will see erythematous lesion, and there are several other systemic disorders which are seen in association with systemic lupus erythematosus. It's a type of lupus erythematosus. The other type of it is called as discoid lupus erythematosus. Okay, I mean, you don't have to know from this lecture point of view, just brief information about it. Okay, so Sjögren's primary will have just sicca syndrome, secondary will have sicca syndrome with rheumatoid arthritis and systemic lupus erythematosus. Both of them affect the connective tissue, and both of them are again autoimmune. So it's a combination of autoimmune disorders. Clinically, you see it at a peak age of 50 years, so it is a disease of the older people. Females are very, very highly affected, and the ratio between females and males are 9:1. When it comes to the incidence on the clinical features of oral pathologies or any other pathology for that matter, even general pathology, it's very easy to remember because most of the lesions affect men. Okay, very rarely there will be a female predilection, so it's easier to remember only the ones which are highly predilection, which carry a high predilection for women, and the rest of them is automatically men. And here you can remember the number, it's 9:1, so they're affected 9 times more compared to the male counterparts. So what are the symptoms of Sjögren syndrome? So we have oral changes, which one of them we've already discussed, that is the dry mouth, and ocular changes, that is the dry eye. So we will discuss these two in detail. And apart from the eye and the oral cavity, the other areas which are affected, or the other secretions you might say which are affected, are the exocrine glands of skin, nose, and the vagina. So there is dryness in all these areas as well. And along with that, there is tiredness and fatigue in these patients. So the patient complains of tiredness and fatigue, and they cannot do anything like this. So clinically, as you can see, females are 9 times affected. So this image is of a female. So there is like diffuse and firm enlargement of the major salivary gland, and it is bilateral, so it is seen on both the sides. It is not really very, very painful, but it could be slightly tender, especially upon palpation. And along with this bilateral enlargement of your major salivary gland, there are also other oral changes which are seen. The first one is the cobblestone tongue. So as you know, the oral cavity, the mucosa of the oral cavity is quite smooth. And except for, of course, the dorsum of the tongue and the hard palate where there is rugae, dorsum of the tongue because there are papillae. But here you see something called as cobblestone tongue. So can you see the difference between your normal tongue and this cobblestone tongue? So this looks like a cobblestone, which you see when you're walking on the path. So that's a cobblestone. Which is laid down. So there is a fissured a papillae, as you see here. There are deep fissures between the papillae, and also there is an atrophy of the papillae, that is the loss of papillae. So this kind of tongue is called as cobblestone tongue. So remember, all these are the oral changes which we are discussing. So that's one feature which we see in the tongue. And the next feature is the parchment. That is, parchment is also dryness of oral mucosa. And this dried mucosa appears inflamed, red, as well as painful. And here you can see, so this is how a parched tongue is going to look. Because tongue usually is coated with a lot of saliva, it is moist, it is glistening, and all the papillae look healthy, and it doesn't look inflamed and red, whereas here it looks extremely dry, and you can see the areas of inflammation here. Okay, it's so dry that it's become constricted, because tongue is a highly muscular structure. It is composed of a lot of muscles. So the muscle has become contracted, as you can see here. Okay, so that's another feature, another oral manifestation. Whenever the pH drops below 5.5 is when the caries occurs. Okay. So the normal pH is 7 to 7.2, and when the pH drops below 5.5, it results in the incidence of caries. Okay. So here, what is happening is there is a lack of saliva. There is xerostomia, of course. There is reduced production of the saliva. So there is a lack of all the functions of the saliva. That is, whether it's cleansing action, buffering action, any of those. So that results in cervical caries. So I hope you all remember the types of caries as well. So this is based on the position when it is seen in the cervical area, that is near your cemento-enamel junction. That's called as sorry, dentino-enamel junction, that's called as cervical area. So sorry, cemento-enamel junction, I was correct. So that area is called as cervical area. So caries, when it occurs in this area, it's called as cervical caries. So that is very common in patients who have a reduced amount of saliva, that is xerostomia. Okay. So like I said, xerostomia caused by decreased salivary secretion, and there is a difficulty in swallowing and altered taste because your tongue, of course, is affected. The papillae have become atrophied, and swallowing is difficult because the saliva actually helps to move your chyme and the bolus down the GIT, like I said in the last class also. So when that is low, then even these are affected. And if they're edentulous patients, because we're talking about older people over 50 years of age, and suppose they have dentures, then there will be difficulty in wearing the denture because there is no saliva. So the denture might just stick directly to the alveoli and the alveolar bone or the ridge, alveolar ridge, and that might be painful for the patient. Okay. So those are all the oral changes. Let me quickly repeat. The first and foremost is bilateral painless enlargement of the major salivary gland, followed by what is called as a cobblestone tongue, where the surface of the tongue is fissured and atrophied. There is parchment of the tongue because of the dryness of the mouth, that is the xerostomia, which is reduced secretion of the saliva, which in turn results in cervical caries, that is the caries of the cervical region. And other functions which are affected are swallowing and the taste. And if they're edentulous patient, then wearing denture can be cumbersome. So that was the oral changes. So next we are going to the ocular changes. So the ocular changes, like I said, is the keratoconjunctivitis sicca, because it's the conjunctivitis which happens here, and the eyes are dry. That's why the term sicca. So this dry eye or xerophthalmia is caused by a reduced production of the tears by your lacrimal glands. As you know, the lacrimal glands are produced around here, present around here, and they produce the tears to keep it, again, there is a thin film of tear always covering your eye so that it's not dry. And dry eye is a condition where people find it very difficult. It's itchy, and it just sometimes there is a sudden production of tear which just drew, without uncontrollably it keeps coming out. So all these are like features of dry eyes, which can be present in normal people also, by the way. Especially those who wear glasses, they will have. And when there is reduced production by the lacrimal gland, it's called as xerophthalmia. Apart from the xerophthalmia, it will have keratoconjunctivitis, which is scratchy, burning, gritty sensation, and painful eyes. Because there is no tear, the cleansing action of the tears is gone. So whenever there is any dust also, it's the tears which is immediately produced as a defense action, and it flushes out whatever has entered your eye. Okay. But in case of a dry eye, there is no tears to do that function. So whatever is entering is like staying there, resulting in itching sensation, burning sensation, and a very painful eye. And there could be blurred vision also associated with these patients. And like I said, it's not just the eye and the mouth which are affected. Any secretion in the body is also affected. That is, the exocrine glands of skin, nose, and vagina are also affected. So the inflammatory process of these tissues will result in dry skin, dry nose and dry vagina, and fatigue and depression. This I told in the clinical features as well. So there are some laboratory investigations which you can do to confirm your diagnosis of Sjögren's disease. The sign of the dry eyes, you can use a strip of the sterile filter paper and you can place it in the margins of the lower lids. Okay, this is to measure the length of the wet surface. So you leave it like for some time, and then you see how far it gets wet. Okay, in normal it becomes wet within 5 minutes up to 15 millimeter length of the filter paper, whereas in Sjögren syndrome, in even after keeping it for 5 minutes, it will be less than 5 millimeters. So that's a sign of xerophthalmia or the dry eyes. You can do what is called as rose Bengal dye test. Okay, you know what is cornea, conjunctiva, yeah? So here is your cornea, this is the iris, this is the sclera, and this is your retina, this is the conjunctiva, right? So the staining of the cornea or conjunctiva to demonstrate keratoconjunctivitis sicca. So this dye specifically stains these two structures, that is the cornea and conjunctiva. And if there are any damaged and denuded areas within these structures, then that is shown. So rose Bengal dye test is another test. As long as the patient is comfortable, you letting use a dye in the eye. And the salivary gland function, which you can do, is by collecting saliva in a special cup. It is called as a Lashley cup. And the salivary flow is stimulated again by using lemon juice every 30 seconds. So you see how much of saliva is secreted every time you're using your lemon juice. And normally in this Lashley cup, it collects about 5 ml within 10 seconds. Of course, in Sjögren syndrome, it will be reduced. Okay, so these are the tests to determine whether the patient has dry eyes and dry mouth. And the best way of demonstrating Sjögren syndrome is by doing xylography. Like I said, you inject a dye first, and then you take a picture of the radiographic picture of the area. That is called as xylography. Okay, so there is a varying degree of dilatation of the ducts, as you can see here, and this is called as branchless tree pattern or fruit laden branchless tree pattern. And if you've been to Japan, if you've seen the cherry blossom, so that's exactly how the radiographic picture appears. Okay, so that's the classic picture which you see under xylography. And there's a lack of normal branching of the ductal system here. You just see all the dilated ducts around this area which is affected. And serological tests which you can do is for various autoantibodies, because it's an autoimmune disease. And there are associated autoimmune syndromes, especially in the secondary Sjögren's disease, like rheumatoid arthritis, which shows elevated rheumatoid factor. So that is another lab investigation. And there is an elevated anti-nuclear antibody called as anti-Sjögren syndrome antibody and anti-Sjögren syndrome antibody B. Okay. There are antibody A and antibody B, which are specific for Sjögren's disease, that can be seen elevated as well. So two factors, rheumatoid factor and anti-Sjögren's syndrome antibodies. And coming to the histopathology, like I said in the definition itself, there will be intense lymphocytic infiltration. This is all of these are acini. Okay, so this is a salivary gland, and there is a lymphocytic infiltration which is quite intense, and you could also see destruction of acini. Here you don't really see much of destruction or necrosis. Maybe here these areas, which doesn't have specific outline and structure like these acini, so maybe you can call them as destructed acini. And you will also see epithelial, myoepithelial compounds, and again intense lymphocytic infiltration all over the gland. Everywhere you will see in between the acini within the connective tissue. Okay, so again, same, more intense lymphocytic infiltration here also, even here. So the treatment is, because we are facing with a dry eye, you can use artificial tears for the dry eyes. And for dry mouth, that is for xerostomia, you can use artificial saliva. And there are other things which you can do, that is by you chewing a sugarless candy or gum, not the one with sugar. That can lead to a whole array of other different problems. So you chew a sugarless candy or a gum so that it keeps on producing some amount of saliva and keeps the mouth moist, and even the juices which are coming out of your candy and gum can keep the mouth moist. Okay, this is one way. And because of xerostomia, there is extensive cervical caries, so you can apply fluoride for the prevention of caries, and that is another way of preventive treatment. And apart from all of this, you can ask the patient to continuously drink water in order to prevent the dry mouth. Okay, so that is another treatment which you can do, which is very simple, and the patient can be asked to carry a bottle everywhere and keep on sipping. Artificial tear, artificial saliva, drink a lot of water, gums and candies, and fluoride for the caries. We'll continue with the next disease, that is necrotizing metaplasia. So it is a benign condition, it is an inflammatory condition, and it is locally destructive. Okay, so that's why it is necrotizing, and it is locally destructive, and it can resemble a malignant process both clinically and histologically. That is why I've put it up here, because the next week we are going to study all the benign and malignant tumors of the salivary gland. Okay, so like I said, it can be confused with a malignant process like either squamous cell carcinoma or mucoepidermoid carcinoma. So these two are salivary gland carcinomas, and the clinical appearance, even some histological appearance, can resemble these two. So etiology is local ischemia. So that's local ischemia that leads to the local infarction of the tissue. It is seen between 40 to 50 years, so it is an older age group, and seen in males. Hard palate, as you can see, it is the site of occurrence of necrotizing metaplasia, and even the malignant salivary gland tumor, like the one mucoepidermoid carcinoma, has a similar clinical picture. It is seen in the hard palate, seen as an ulcerative growth. Okay, that's why you have to be very careful in differentiating them. And indurated swelling, I hope you all know about the borders, whether it is indurated, inverted. So this is an indurated swelling. It can be present with pain, or sometimes there can be paresthesia. So I've told you what is paresthesia. It is partial anesthesia or partial loss of sensation. And the main feature, the reason it is called as necrotizing metaplasia, is that there are necrotic tissue sloughs. Okay, this leaves behind a crater-like ulcer, which is very similar to a malignant salivary gland tumor or any malignant ulcer, even squamous cell carcinoma of salivary gland. Okay, so that's the clinical picture. And coming to the radiographic picture, there is again extensive lymphocytic infiltration, but it is not as extensive as we saw in Sjögren syndrome. And along with that, there is squamous metaplasia of the salivary gland ducts. Okay, so all the salivary gland ducts, which will have a typical ductal epithelium, has undergone squamous metaplasia and resembles squamous cells. Okay, so that's the histopathological picture. And how will you differentiate from a malignant disease or disease process is that in malignancy you will see a lot of pleomorphism, dysplastic features, atypical mitosis, all those features which we have discussed in dysplasia will be seen. And of course, along with those features, that is the lymphocytic infiltration and squamous metaplasia, there is also acinar destruction or acinar necrosis, but this can be seen in malignant variety also. But one feature here is that there is a preservation of the lobular architecture. So the lobular architecture is saved or preserved even despite the necrosis which is seen. So this is a normal picture which I've put here for you. So this is how a normal acini looks. Okay, this is a serous acini, and this is the mucus acini. And in the disease process, this is how the acinar destruction looks. It has lost all the architecture, all the lobular structure of the acini is gone. And apart from that, there can be pseudoepitheliomatous hyperplasia, and some amount of squamous metaplasia is also seen. This is a beautiful picture. If you see, the lobular architecture is preserved, but inside it is showing necrosis. Okay, even here you don't really see this mucus acini, the structure of it, but then around it there is a squamous metaplasia. No treatment is needed for this because it is self-healing. Another way you can differentiate it from a malignant process, because what they say is you wait for 2 to 3 weeks. If it is an inflammatory condition, not developmental, if it is an inflammatory condition, if it is any such disease, then it will usually heal within 2 to 3 weeks. If it does not, if it increases in size, or if it has any other symptoms, then you have to doubt that it is a malignancy. But however, in this case, you have to take a biopsy because the site, the appearance, everything is very, very similar clinically with mucoepidermoid carcinoma. So just to rule it out, you do a biopsy.